Julianne Ehlers. I'm the project director for NEMSIS. Thank you so much for joining us this morning. We have a full agenda. We appreciate you taking time out of your busy schedules, and we'll keep this moving as we have a lot going on today. Please feel free to unmute and comment or ask questions as they come up throughout this conversation. Also, you're welcome to use the chat feature. We'll be watching that. So if you have questions, depending on the agenda, or if you want to save them for the end for the open forum, you're welcome to do that as well. This implementation call is being recorded, so we make this available to everybody on our website and also on our YouTube channel in case there's a section that you want to go back over, or you have a team member that needs to view a part of the discussion, or you want to just review it for any reason. These are made available on our website and on our YouTube channel. Thank you so much for everybody who's identified themselves as a participant. We do track participation for the vendor participation requirement for compliance, and we appreciate so many of you being with us today.
Right, well, you know it's going to happen.
If you would, go ahead and mute your phones until you're ready to ask a question, and that'll help us keep down on the feedback. All right, let's get this up for today. This morning is March 11th. This is the NEMSIS V3 implementation call. Thank you for joining us. We appreciate you taking your time out of your busy days. We're going to go ahead and start off with Clay. He's going to take our first topic of the day. Clay, do you want the screen or do you just want to talk?
I'm going to ask if I could have the screen just
Absolutely.
To share a quick PowerPoint presentation. All right, can folks see my screen with the implementations NEMSIS slide up?
That looks great.
Okay, great. So yeah, thank you very much for joining us. Folks will remember last week we sent around an email on both the NEMSIS Google group and on the DMC listserv asking for states and for vendors to provide us with some of the approaches that they are taking based on feedback from their stakeholders to deal with identification of and kind of documentation of potential COVID-19 cases. This was a topic on the call 2 weeks ago when this was first an issue. Now it's become a much more important issue, where the idea has been perhaps if there's a way to nationally standardize our approach to the identification and documentation using the NEMSIS standard, that might provide some valuable ways for folks like the CDC, NHTSA, and others at the state level to be able to more clearly identify cases in ways that would be helpful if the approach is standardized compared to different time frames for travel questions and other variations that may occur from state to state or from region to region. So the idea here in just the next 10 minutes is for me to just quickly review the information that we've received from states and from vendors, review that quickly, then we'll call some questions at the end to see if there is a strong consensus for the idea of trying to standardize some part of these approaches. And I'll also mention that we have special guests that are with us today from both the CDC and from NHTSA related to this specific topic, so we can ask the experts any questions that we may have about the approaches that states are taking or vendors are taking, or any approach that we'd like to attempt to standardize. They are available on the call to answer those questions. So thank you so much for joining us. I'll just go ahead and dig in and go through the slides, and then after we'll open it up for questions and comments. So let's go ahead and move forward. So I'm going to just start with the state approaches that were sent to us. There is some variability here that I'll try to point out that may be valuable. The first one I'll just mention here is an approach that's being taken by Georgia in regards to travel. They have built a constellation of elements you can see here that start with the term IT for image trend exam, and their questions here are related to travel. I think many other states have used this as a benchmark for elements that they might be interested in collecting. The interesting approach that Georgia is taking here is it's not only travel, international travel, but the specific question is IT exam dot 070, has the patient traveled outside of their community in the last 30 days? And then you'll notice there to the sub-bullet, community can be defined by the medical director and need not be limited to travel outside of the United States. And so I think this piece is probably in play just because of the idea of community spread, and perhaps that question could be valuable to help identify exposures. Is there anybody on the phone from Georgia? David, do you happen to be on the phone? I apologize, I didn't look at the list of participants this morning who may be able to call out some additional particularities related to their idea of capturing travel. Okay, well, you can see they ask for a beginning date and a travel ending date, and then the locations, and that, of course, could be local travel, outside of their local community, or international travel. And I might also note that they talk about travel in the last 30 days. Washington State just came out with this assessment criteria that's being used in that state. Of course, they are kind of an epicenter right now and are working very hard to control outbreaks that are occurring in senior centers. So I'll just walk through their assessment criteria here. So does the patient have a fever in conjunction with their current illness, the onset, the temperature? Does the patient have symptoms of lower respiratory illness? These are the common questions that CDC considers that we ask: cough, difficulty breathing, and then symptom of onset. And then related to travel, have they traveled from China in the last 14 days? Have they had contact with any person who recently traveled to China and is sick? And have they had contact with any a person with a confirmed or suspected case of COVID? And then the nature of that contact. Then if exposure to COVID is suspected, there are two ways the answer to that would be yes, that is fever and respiratory symptoms and travel to China, or fever or respiratory symptoms with contact with a confirmed case. And then they go through the process of what the provider should do if they suspect a COVID case. So a little bit more inclusive, clearly with clear delineation of the symptoms, and then also uses 14 versus 30 days. Wyoming, I'll just throw this up. Wyoming uses a much broader approach, I think, and Jay may be on the line. I think Jay is on the line. I know that Wyoming put together this other custom element that just looks for suspected influenza type illness. Jay, are you currently using this element, and are there other elements that you're using this in conjunction to deal with COVID?
We're using this element, and we're reporting this to the epidemiologist every morning. A follow-up on that, if just looking at what Washington put together, nice job on the slide, we are about the exact same thing.
Mm-hmm. Okay.
Have been monitoring that. We're getting a fair number of reports every day. We're not getting 100%, but we're probably getting, I'm going to guess, 30% of our contacts per day in reports.
Okay, great. And are you using 14 days or 30 days for the travel?
14 days.
14 days. Okay.
Clay, we did have a question. Is this for Georgia? When you had Georgia up earlier, is it part of the Georgia Schematron?
That's a great question. I think there are Schematron rules associated with their custom elements. I'm not sure. I'm not sure. We could look into that. Oh, who is that? I'm sorry.
It's Jen. Yeah, we send it to them in the Schematron. Okay. It's part of it.
Okay,
yeah,
great.
This is Josh. Just to clarify, it's part of Georgia's state data set and has been for some time.
Mm-hmm. Great, thank you. Okay, super. Just one more here. Colorado sent me an interesting note from Amber, and perhaps Amber is on the phone as well. She indicated that they've added a waivered act for their EMS providers, which allows them now to do nasal and throat swabs to test for COVID-19. And to track these the testing that's done, they've activated the following procedure code and are currently working on communication with their providers and using the new code. I know it probably looks very small too, and I apologize for that, but there is a, under the yellow, the orange active values and codes, there's a new code that they've added that deals with nasal or throat swab specimen. So it looks like they're expecting to be able to do testing in the field. Amber, are you on the call, perchance?
Yep.
Oh, great. Amber, could you describe this a little bit more, this waivered act that you've developed there for Colorado?
Yeah, so previously only community paramedics could do the nasal and throat swab. So our state medical director pushed through this waivered act that all of our medical directors can establish protocols so that any EMT or paramedic can now do the swab test. And so they're being sort of facilitated at the local public health level, but they're sending out our EMTs and paramedics to actually do some of these testings in the field.
Great, great. Any questions for Amber?
Hi, Clay. This is Greg Mears. How are you?
Yeah, hi, Greg.
My only thought was that if we are going to create questions, it's no longer just an issue of traveling to central China. I mean, certainly Italy and some other hot pockets in the global state of things are significant. And so I think traveling outside of the U.S. may be a marker, but I don't think that we're at a point anymore to where it's just traveling to China.
Yeah, that makes perfect sense. And your point is well made. Even when we're looking at these criteria, I'm sure that they're changing very rapidly. Even with clearly community spread, travel even within the United States may also be an important question to ask. I'm sure this is changing very quickly. Yeah.
It may just be travel, yes or no, and then stop at that point. But certainly there are hotspots that we could ask about, but that's going to be changing on a weekly basis. Yeah,
great point. Great point. So I'll highlight a couple of vendor approaches that were just sent to us, and of course these will mirror fairly closely what the states are doing, just because the states work very closely with their vendors. Here's what Image Trend sent, just a summary of several fields and presentations on their GUI that cover fever, associated symptoms, travel, and then history of event. So you can go through these and look at them. They're a little bit more generic, a little bit like what Dr. Mears was talking about in regards to travel. They do ask specifically about China, but talking to them just yesterday, they've also taken this approach that they need to be looking at travel outside the U.S. and some travel within the U.S. So fever again, cough, sore throat, difficulty breathing. Sore throat is one that you don't see across all states and vendors. And then in regards to history of event, some interesting questions. Is the patient a member of a cluster of patients with severe acute respiratory illness of unknown etiology? Has the patient been evaluated or diagnosed with an acute respiratory illness? Has the patient had close contact with a suspected or laboratory confirmed coronavirus case? So I'll let you just take a quick look at that. We also received ESO during their conference, I think last week, released their EHR application flow for COVID-19. You'll see it's very similar to what we've seen so far for primary and secondary impressions, fever, cough, shortness of breath. Infectious disease and respiratory disorder are not found on all other screenings that we've seen. Signs and symptoms: respiratory distress, sore throat, cough, shortness of breath, difficulty breathing. the outbreak screening, time of onset, with the symptoms, is there a history of travel outside of the community in the last 30 days? And so they've taken the approach of outside of their own community. Travel start dates and locations, and then has the patient traveled outside of the U.S. in the last 30 days? Start date and end dates, and then countries that have been visited. And has the patient had household or other close contact with someone with the above travel history and symptoms? And has the patient had household or other close contact with someone with a confirmed diagnosis of the illness that you're screening for? So lots of similarities. There's clearly some differences present in these approaches. And then just quickly, just the last few slides, maybe just to go over a little bit the guidance that's been offered by the CDC. So there is coding guidance that's been offered. It's not necessarily coding that was directly focused on EMS coding. Hospital coding was, I think, the focus, but clearly we may want to do something here. So they've just called into effect 2 Z codes, basically, that could be used to document concern about an exposure or a positive exposure to a communicable disease. And you can see those Z03 and Z20 codes. And then the signs and symptoms that we talked about throughout these screenings, cough, shortness of breath, and fever, they have identified specific codes that they think should be looked at. I'll just show you, we in NEMSIS, of course, because we use suggested lists instead of very defined lists, the idea, cough is pretty straightforward. There's really only one code that's available for cough, R05. But when you look at shortness of breath and fever, the codes can be a little bit more spread out, and our providers use those codes in greater variability than just the specific code that the CDC was, for example, requesting. So here's an example of maybe some codes for shortness of breath that we may want to capture with a broader net rather than just a single code that indicates shortness of breath, R06.02. Clearly, we're using other codes that also speak to forms of shortness of breath, dyspnea, orthopnea, things like that that may be valuable to include. Fever is a little bit more specific. So you look, there's a number of fever codes, but you'll notice that there's really probably only 3 codes that speak to fevers that are not specific to another reason for that fever that I think EMS might be able to easily determine, right? If it's a fever due to a recent surgery or immunization or drug-induced, perhaps those don't need to be included in some type of a constellation that we might use in NEMSIS if we're not requesting specific codes. And of course, we haven't done that so far in the past. Then I'll just make the point that, of course, we do in the primary and secondary impressions, the code set, the code pattern includes the ability just to identify influenza, for example, or even things that could be influenza or pneumonia. It's really hard to put yourselves in the heads or to put yourselves in the mind of a basic EMT or a paramedic and what they might actually code influenza-like symptoms as, right? So here's just a brief example using the 2018 data of the number of primary impressions that utilize a series of codes in the J section that may be related to an influenza type exposure. So that's an overview of what was brought into our offices here over the last week. Thank you for the folks that have sent those materials in. So really, we'd love to have a conversation, and if the CDC or NHTSA would like to make comments, we'd love to hear from them. We'd like to confirm a path forward. We talked 2 weeks ago about the idea. There was fair consensus at that time about developing a travel-related national custom element that would be available in a repository in the national section, not the state sections, but in the national section that all states could utilize, all vendors could utilize. maybe this past week we may want to add another national element that is some form of contact with a confirmed case. And then clearly we could add the CDC recommended Z codes to the suggested impression list for secondary and primary impression that we maintain here at the NEMSIS TAC. And then other ideas that folks may have about what we might want to do as an industry in regards to the identification and documentation of COVID-19. So I'll open it up at that point for any comments.
Hey, Clay, this is Myers from ESO. Thanks so much. Just a couple of observations about the ICD-10 codes. There is the Z828 does apply pretty well to EMS, but the other one that had exposure, if you read that one all the way out to the end, it says, and thus ruled out. And I don't think EMS is going to know that right there. So the Z03818. So we elected to for right now to map to Z20.9, which is just a general exposure question. So if you got a suspected case, but it's not been confirmed, because we didn't feel like EMS would be able to actually rule it out. So we did not elect to bring in that code, and rather just mapped it to the generic Z20.9, just for your information.
Okay, great. Z20.9. Thank you.
This is Jim Jansen in Washington State. So I think one important consideration as we look into what a national structure might be is how we intend EMS data to be used in patient tracking and COVID-19 tracking over the long term. So in our conversations with our incident management team and other epidemiologists here, it's pretty clear that I think that the use case for EMS data really is going to be backtracking confirmed cases from hospitals and also providing alerts to potential cases to do tracking on. But I think that the majority of cases that are identified as potentials from EMS data are going to be tracked and traced using ED confirmed diagnosis and hospital kind of epidemiology tracking. So I think in light of that, I would push for a wide stroke on capturing patients. So yeah, like ESO is saying, to look at a Z20.9 code to kind of capture all of those with a broad brush, so that we have potential patients for epidemiology teams and hospitals to backtrack to specific locations or where there might be a cluster, and they can kind of use that data retrospectively to identify other potential cases.
Thank you, Jim. Other comments about those two potential use cases? So, Jim, I'm just going to expand on those to make sure that I've got them clear. So you're talking about the potential use cases that Washington is very interested in looking at is backtracking exposures after they're confirmed in the ED, right? That's one, is that right?
Correct, yes.
And then the other is just active tracking of identified cases. Can you describe that one a little bit better?
Well, I guess we're just thinking of how an EMS provider would actually interact with the patient if they identify that they were a potential COVID-19 patient. There would be the need to alert the hospital of that patient, kind of get the systems approach into play. So being able to identify potential cases and then being able to have useful information for patient tracing, looking backwards if patients are identified as COVID-19 patients in the hospital.
Great. Thank you, Jim.
Clay, this is Jay in Wyoming, and one of the things I was asked to put together, and I'm hoping I can push this out and maybe come up with some smart people's input, is I was asked to put together either some sort of a risk from the questions that we have in there, or some sort of identification logic into that. I've kind of tinkered with that, and I was kind of hoping I could bring it up during this call and see if anybody has some concepts that maybe we could put together to help the providers, say if they score high in some areas, such as they have fever, other conditions. So I'm just going to bring that out for discussion and an idea, and maybe we can come up with a concept on that. I hope that kind of makes some sense on there.
Yeah, Jay, so you're saying kind of weighting the questions, right? There's some that a positive answer to some questions may have heavier influence in regards to the identification of a case compared to another question type of thing, so weighting the questions, right?
We won't maybe be able to identify the fact that it is COVID-19. However, we may be able to identify that additional precautions, as the higher the score may be, additional precautions could be applied, or they could notify the emergency room they're coming in with a score of a high of some sort. So, you know, my fear is that the field guys may get, how would we put it, exposed. But the last thing I want to see is, you know, if they get exposed, okay, that's we don't want that to happen. But I don't want to see an ER be overran where they have to take and quarantine their people for a fair number of days also.
Hey Jay, it's Felicia from Utah. Have you guys talked to your dispatch agencies? Because our dispatchers, like our dispatch, one of the bigger ones in Salt Lake City, they already have like an enhanced screening when the caller calls in, if they kind of meet certain criteria. And then from there, they should ask other additional questions about travel, contact with community, exposure, that sort of thing. So we're hoping that'll flag it to the EMS providers at that point. And we're hoping they'll start using more like the pandemic, outbreak, epidemic dispatch code instead of just like sick person, which they're kind of choosing to use right now, even if they meet that criteria. So we're going to have discussions more with those guys as well.
Yeah, our state epidemiologist and state health officer, we had a conference call, and I think we had, I'm going to estimate about 18 to 20 dispatch centers on that call. And one of the interesting questions was, when should we institute this? And the answer was, of course, yeah, we should probably do it now and just be ahead of the game. So I know that that's being instituted and warning them, and hopefully that advanced notice gets in there. And that's a big point. Thank you. I just totally overlooked that because I'm concentrating mainly on EMS. So thank you again.
Yeah, ours hasn't, I think, 100% implemented either, but they've started to. But we're trying to kind of, I don't know, maybe kind of guide them to use the 36 code instead of, quote unquote, sick persons, what they want to use.
Mm-hmm.
So just thought.
Good thought.
All right, great comments. This is Clay again. Maybe we can just speak to the direct questions on this slide. Do folks still feel like it would be of value for NEMSIS to define a travel-related set of questions that we provide as a national custom element? Do folks feel like that would still be valuable?
Is this just for coronavirus or everything in the future as well?
Well, I think we would try to make it be generic and not only speak to travel outside of the United States, but also travel with kind of outside of your community. I think we would, just based on what we've seen and the profile of this outbreak and past outbreaks, that we would try to just indicate whether or not the patient has traveled outside of their own community and whether they've traveled internationally as well.
I think it's a good idea.
As long as they include like the unknown or patient refused to answer, as long as it includes an out for the crews if they really can't get the information, I think it's a really good idea.
Including pertinent negatives is a definite possibility for it. I agree with Jen completely on that. The use of pertinent negatives across the country is not well educated, at least in New York. I agree with Jen completely, but have we thought about asking questions about attending larger gatherings like churches, graduation, school concerts?
Hi, this is Dave.
In New York, it's been spread all over through public.
Okay, no problem. I get that.
Yeah, that's good. So, hey, someone is on the line who isn't muted. You're speaking to someone else in your...
I totally understand. I saw you guys put out a state of emergency.
Looks like it's Dave Zaman, Biospatial.
Hey, Dave Zaman.
Yep.
Okay. Well, can you send a message to Dave, Bridget?
No.
Thank you.
And Clay, I'm going to go ahead and mute all, so we'll unmute you, and
I've
then
been on calls. I just got off a call with Brian.
Okay. All right. That should do the trick too.
Okay, great. All right. So Peter, great questions. So first off, you mentioned pertinent negatives, and so you'd like this element to include pertinent negatives, so they could, for example, refuse to answer, that type of thing. That's Peter, are you there? You may be muted, Peter. You may have to unmute. Okay, well, maybe Peter, let's see.
I think Julianne might need to unmute everyone.
Hey, Clay, it's Jen.
You're doing so maybe I can understand why.
It's *6 if you want to unmute yourself. Yeah, the pertinent negatives, because that is something when we put these in at first for Georgia, we ran into pretty quickly the fact that some patients would refuse to tell you, right? You don't need to know where I traveled. You don't need to know where I've been. And so we needed those pertinent negatives added in so that we could allow the crews to ask the question as we were requiring of them and mark the answer that they got from the patient. And then there was the passed out patient, right? The unknown unconscious patient that you couldn't ask them. No one around them knew them. There was no family. So that was why I made the comment about the pertinent negatives.
Oh, thank you, Jen. And then how do people feel about including in this question the attendance to large gatherings that Peter brought up?
We need to clarify what that might be. Like if they went to school and they were in the auditorium, does that count or something like that?
Yeah, we can work on some language. Peter, are you back with us? I wondered if maybe Peter had worked on some language. I'll contact Peter just related to his comment and see if New York's done any work on kind of defining what is meant by large gatherings.
Clay, in the comments for group chat, there's several different participants that have expressed support for a national element.
Great, okay. Okay, super. I'm reading through those comments as well. So we will go ahead and keep track of those comments and ensure that they're considered when we scope this out. We'll try to have this ready long before the next call so that folks will have a chance to review what we're doing and then get comments back. How about the idea, sorry, other questions related to travel? Related question?
I got two, or I have a question and a comment. First one is, if we do mimic Georgia's, we just need to sort of be cognizant of the fact that Georgia's pertinent negatives are just built as normal list values, and we need to make sure that they are pertinent negatives. And then I know someone from the CDC is representative here. Do they have any guidance on the large gathering questions?
Yeah, thank you, Keenan. Comments from the CDC about a large gathering question?
Hi, this is Jeff Ratto. Can you hear me?
Yes, Jeff.
Hi, Jeff Ratto, CDC. Can you explain a little further the questioner, what you would want to know about the large gathering question?
Yeah, I wish Peter was back on. So Peter is the EMS data manager for the state of New York, and he's the one that brought up the idea that, it would be valuable to look for travel outside of the United States and maybe travel outside of your community, but maybe including a question that talks about whether or not the patient had recently attended a large gathering. Now, how that's defined, maybe Peter can get back to us to kind of see how New York's defining that, but I wondered if the CDC had talked at all about what might constitute a large gathering for the CDC. Have you folks talked about screening in that way?
Yeah, I can check with the response about this. If I get back to you, Clay, would that be helpful?
Yes, that would be very helpful. Thank you.
Clay, this is Peter. Can you?
Yeah, Peter, we heard you there for a minute. Yep.
The phone keeps muting me. Can you still hear me?
Yes, I can. No, thank you.
Okay. The question we had is in New York, many of our persons under investigation were found after an individual went and attended temple. So he went and attended temple that was well attended in a large populated area. And they've identified many individuals who became PUIs and some with diagnosed after their investigation in that particular regard. So when we're talking about larger community events, we're talking about those events that may have had upwards of 100 people or more, where we'll want to look to see if they were in close proximity and enclosed environment. It's the approach that New York has taken, and we're tracking all of those back as part of our response.
Okay. All right, so that provides some parameters around what you're describing as a large community event.
Okay, so you would consider like a school assembly to be inclusive of that?
I would, yes.
So Clay, this is Jen from GMR. I do have one thing I want to say. I think the national elements are a great idea. But right now I know we're getting shorter and shorter turnaround times as the influx of patients is getting heavier and heavier on our crews. So I want to make sure that anything that we do decide to go with, we make as succinct and as I think we just need to be careful how much of a load we put on our crews for filling out their documentation, that we don't add so much that we get them into the pick off the top of the list kind of mentality, so that they can get their paperwork done so they can move on to the next patient, kind of thing that we've all heard about. But of course, none of our people ever do.
No, Jan, it's a really good point. I think what we would try to do, we're kind of late to the party, right? So I think what we would try to do is mimic as close as possible what's already being used, what's already out there. You're right, and not trying to add lots of dimensions to this to the point that it becomes burdensome. Yep, that's a really good comment. Thank you.
And I agree. This is Jim from Washington. I agree with that, and I would just add that I think a good thing to think about is what is the hole that EMS data could fill with this, and not necessarily trying to do anything that might overlap with information that's already being collected through patient tracing.
Okay. Okay, fantastic. So those are great comments, I think, that relate to any element that we add as a national element related to this outbreak.
This is Chris Haas with Document Systems. I just wanted to chime in with a comment I was getting ready to make relative to what the gentleman from Washington State said and others. We need to be careful that we don't overwhelm EMS with questions that can better be asked and traced in the hospital setting or elsewhere. And I guess our objective has been to identify at-risk patients and some information which can aid in tracing, but not to go overboard. Is that what I'm hearing? That's what our basic philosophy's been.
Yeah, this is clear. I think that what you're hearing. So Jim from Washington, how about, so let's flesh that out a little bit. So this idea, if you're just trying to identify at-risk patients and doing some tracing, what would you limit the questions to, Jim?
I think, mean, travel outside of the community, I think is a crucial one. I'm thinking more about patients who are not transported to the hospital. I would venture to guess that many patients treated by EMS for flu-like illness are not transported to the hospital, especially with mild conditions of coronavirus in younger patients. That I could imagine cases where a patient, let's say at a homeless encampment, for instance, or other close residential area, or perhaps one patient from that area is transported to the hospital and identified with coronavirus. What would be the useful information from the EMS data about that community in general, in terms of have they had an abnormal increase in flu-like illness calls by EMS that perhaps weren't transported, and do we need to add those cases into the pool of potential patient tracing population? And what data can EMS provide that would help the epidemiologists doing? Very good point.
Yeah, good point. Thank you, Jim.
It's Frank Sloan from R1. We have a really wide variety of requests from our agencies. Very large cities are looking at this as we already track flu-like symptoms, and that's the best we can do and want to change for our providers. And then we have more rural agencies where they've developed a check sheet and they have the time to fill that out. So we've kind of been following our customers, dictate on what they can and want to do, but as minimal impact to workflow for large, busy EMS systems is what we would want at the national level.
All right, that sounds good. So this idea of travel, I think we've got some great ideas here related to this. Also, this idea of some tracing relates to this second question of whether they've had contact with other sick people, other confirmed cases or sick people. Do people feel like that's so say we have just one or two additional travel questions, maybe just outside of your community, and then where in the last 14 days or something like that. We can frame it up and then we can spend time proofing it a little bit. We'll put it out on the Google group and also the DMC listserv. But do folks feel like there's also value in adding a contact with confirmed cases or other people with similar symptoms?
Clay, this is Greg again. I think there may be some unintended consequences with this, and we just have to think through it. I'm not saying that the ideas are bad at all, but what we're starting to see is that if you hit on any of these questions, then they're quarantining the entire first responder and EMS crew for 14 days. And I don't know of many EMS agencies that can have 6 or 8 crew members knocked out just because of one case when they're healthcare workers. So I think you just have to think through that. Is you can be very aggressive in trying to document every case, but at the same time, it may have its issues with balance of how you staff and keep your operation running.
Well, I would agree with that. I would add, though, that this is Jim from Washington. I would add that we will likely get to a point where individual patient tracing is not the only need for data, but we'll be doing. We expect to be moving to a process where we'll be doing more community tracing of movement of the virus. So it may be that it's not, the EMS data might not be only used or primarily used for individual patient tracking, but might be used to define a region at higher risk or a community at higher risk or a neighborhood at higher risk.
No, I think that's great. I think the question is that we need to, at the same time we're implementing these elements, do we need to require or to document the type of hazmat personal protection equipment associated with that. And that's a risk, both a risk management as well as a public health issue.
And
this is Ann in Arizona.
Jen.
I don't know if I'm.
Oh, sorry, Ann. Go ahead, hon.
Oh, it's okay. Sorry, I wasn't sure if I was still on mute, and I'm in the parking garage because I just got done driving in. So for our state, the only thing I've sent out so far is just kind of an optional recommendation, kind of telling agencies, hey, just so you know, there are PPE questions. It's I can't remember the debt element, it's the other something, but available, and also don't forget to add in your crew member with it so you can document which crew member had which PPE. And then some guidelines were put out. There's a slide presentation that they did and a call for all EMS last week, and it's available on our website if anyone's interested, kind of going through a scenario-based algorithm where, depending on what PPE you were wearing when you were potentially exposed, what sort of measures as EMS you should take as far as isolation. I don't know if that's helpful information for anyone, but that's kind of what we've done here.
Thanks, Ann. Hey, Jen.
The only thing I worry about developing a national element with the contact with a confirmed case is who's saying that it was a confirmed case. I'll give you an example. I have a family member who is the worst hypochondriac in the world, and she shopped in the same store as the person who got coronavirus in one of the areas that I'm near. And so she immediately said she had had contact, and she knew she had a fever, and that, you know what I mean? Like, and I worry that if we ask the patients if they've had contact with a confirmed case, who's telling them it was a confirmed case? Do they know it was a confirmed case? And could we possibly get people tracking the wrong thing if we're providing that information from our system?
Well, I think that's where acknowledging that it's a broad brush that EMS is providing. So we can cast that wide net, but not miss people. So I would imagine that the number of false positives from the question of whether they've had contact with a confirmed case will be relatively low to the specificity of whether somebody, I think if somebody knows that a family member has a confirmed case, and that's going to be very accurate information and important. But I would be more concerned about missing the true positives than collecting the false positives.
And Clay, this is Brent from ESO. I just sent you the three that we're using. And to that point, when we added the elements, we put in confirmed by testing as the phrase. And then in the education around it, it has to be someone that literally was confirmed by testing, and then exposure to that confirmed patient. And then the broad brush one that folks are talking about is that Z20.9. So that's how we kind of skin the cat. I know there's probably different ways to do it, but those three codes made the most sense to us. The patient was confirmed by their own testing. They've been exposed to somebody who's been confirmed by testing. And then a broad net of, hey, there was some concern on this call about it, but we can't be more specific.
Thank you, Brent. Yeah, I'm trying to, for some reason that won't open for me. Would you send it to me one more time, Brent, and I'll share it on the screen? Thank you.
Sure.
Okay. All right, so hearing kind of some mixed feelings about the content of a confirmed case, and also thank you for those that are providing comments as we go along. Those will be considered, so thank you, and continue to comment if you wish to just have something on records. So please continue to do that as well.
Right, so that element would only be for this current outbreak. Might not be useful for in the future, unlike the travel ones.
Yeah. I guess if there was ever type spread again, that you'd want to. I think the idea of tracing would be to identify clusters, or some type of epidemiological mapping back to exposure. So and I would imagine if it's viral or bacterial, that there'll be some type of community exposure.
All right. So,
all right. Yeah.
Could the question you're talking about now about the exposure be phrased in a way that's not just for COVID-19? Just another thought on that.
Right. Yeah. We would. Yeah, and I'm trying to Brent, maybe just for some reason, I'll pass those out to folks after the call. For some reason, it's not opening, and it may just be because I have Zoom open. Sometimes things are funky in that regard. But yeah, I think the idea would be more like Brent's questions that are mentioned.
Could you copy
here
an email, Brent, if you could, instead of the spreadsheet, perhaps?
Yeah, I'm sending an image of it now.
Yeah, thank you, Brent.
I just took a screen capture of it. Yeah.
Okay. But maybe something like these two questions down here, David, right? So has the patient had household or other close contact with someone with the above travel history and symptoms, right? So that could apply to any exposure. And has the patient had household or other close contact with someone with a confirmed diagnosis of the illness for which you were screening? Something like that. Let me look and see if Brent's emails come through. Okay, not yet. I'll continue to look for that, Brent. Thank you. All right, I don't want to burn all the time, so we will provide these comments back in a more condensed form and I'll provide some recommendations. This third bullet of adding the Z codes, the ones that Brent will share and others to our suggested lists, we'll certainly do that here at the NEMSIS TAC, and so those will be available. We'll make it available to all states and vendors what we've added to those suggested lists. Are there other ideas on top of those three ideas that we've talked about that folks feel strongly about, either vendor, state, or federal agency? Okay, thank you, Brent. Here's the code set. It's going to look a little small. See if I can zoom it out here a little bit. All right, so can folks see those codes? ICD-10 codes?
Yeah.
All right. Thank you, Brent. Any other comments related to this topic? We've taken a full hour of time. Thank you very much. This has been incredibly helpful. Any other ideas that folks want to discuss on this call while we have very busy folks at the CDC and NHTSA on the call?
This is Sharon in Nebraska. Someone had mentioned this, but I just wanted to be sure that you caught it, that for the EMS provider, there is that other that is a type of death versus exposure. So for the provider, EMS provider, there is an element that would somewhat capture some of that.
Right. So Sharon was breaking up a little bit. I think Sharon's making the point that in the other section we have a component of elements that deal directly with exposures to EMS personnel. Right, Sharon?
Oh, yeah. Sorry, I had my microphone messed up. So sorry.
Oh, yeah. No worries. No worries. So that is available for personnel exposure. Okay, Julianne, thank you very much. I'll turn the time back over to you. Thank you for the comments. We have our work cut out for us. We'll try to provide some consolidated comments regarding some national custom elements, and we'll make those available very soon. And we'll share that either through the Google group, the NEMSIS Google group, and through the DMC listserv. So if you're associated with either of those two lists, you'll receive copies of it. All right, thanks, Julianne.
Okay. Next up is Josh, and Josh has a few topics. We'll move pretty quickly through these last few topics, but if you've got questions or comments for the next following topics, please feel free to ask those, and then there will be open forum at the end of this agenda as well. Josh, do you want a screen, or do you want me to pull up the website? What would you like?
I'll go ahead and share my screen and run through these three topics I have. Give me just a second. Okay, did that bring up the NEMSIS website?
Looks great.
Great. Okay. Just 3 quick topics here. First, last week I did a training that was targeted to state data managers and software vendors, I should say state-level software vendors, on writing efficient business rules. And there were a few tips up at the beginning of the presentation, and then most of the training focused on this concept of embedding a state dataset file within a state schematron file so that the schematron rules can reference data that resides in that state dataset. And that ensures consistency between your validation rules and what's in your state dataset. So I'm on the state training sessions page of the NEMSIS website right now, and you'll see the link to the YouTube recording of that training session is here near the top of that page. So that's the first one that I had. Second topic I have is the updated schematron rules for NEMSIS 3.4. Let me get to where we have posted the draft of those. So this is the schematron page under technical resources. And there's a link right up here at the top to a draft of the updated V3.4.0 schematron rules. That takes you into the NEMSIS public repository to a feature branch that we've created for this draft, where you can access the schematron rules themselves, as well as the documentation. So I showed those to you a couple weeks ago. We're going to go ahead and finalize those rules and make them public in the release 3.4.0 branch of the NEMSIS repository around the end of this week. So before we do that, I wanted to ask, is there anyone on this call who has tested these draft rules? I know you've probably been a little busy with coronavirus stuff. I want to see how many people have tested these new rules. All right, I'm hearing silence on that. They have been tested within the NEMSIS TAC, but the NEMSIS TAC only has access to national data, national elements. And I have also been testing them as I have been updating the Schematron sample files, the sample test case files. And I have made a few corrections as I've been working on those test case files. I've got those all written and those corrections prepared, ready to publish in the final release. But now's your chance. You've still got a couple more days to go ahead and download these draft Schematron files, run some of your existing data through these rules, and make sure that you're getting validation results that are consistent with the old files, but in this new format, and make sure that you're getting validation results that seem reasonable, that you're not getting rules triggered where they shouldn't be, or so on. Okay, so between now and the end of the week, if you've got someone, especially vendors, if you've got someone who can run some of your existing data through these rules, it would be very helpful for us to know if there's any issues that we didn't catch in this draft. Any questions on the Schematron update? Okay. And the last topic I have is another update for the performance measures web service. I'm going to go to the web services page of the NEMSIS website and scroll down to the bottom where there is some information here and links about the performance measures API. I'm going to go ahead and go over to the performance measure definitions. Oops, we got someone who's unmuted. Okay, here on the performance measures definitions, of course, last month we released Safety 01 and Safety 02. This month, as of yesterday, we have done a re-implementation of Stroke 01 and Trauma 01. The reason for re-implementation is because we implemented the EMS Compass performance measure definition, but NEMSQA, the National EMS Quality Alliance, they took those EMS Compass definitions and they made some adjustments to them. They quote unquote respecified them. And so we have now moved stroke-01 and trauma-01 to implement the NEMSIS specification of these performance measures. So here in the performance measure documentation for stroke 01 and trauma 01, you will see the current NEMSIS specification of these measures, and that's what's now available through the performance measures web service. Let me show you here in this wiki site. You can go to page history. You can you can select a previous version of the page and you can compare it with current, and it will show you what changed in these specifications. So in stroke-01, NEMSIS added several ICD-10 prefixes for primary and secondary impression. So they're casting a wider net in terms of what might be considered a stroke. However, they also added an exclusion to the denominator so that calls where the total GCS is less than or equal to 9, or calls where level of responsiveness is unresponsive are now excluded from this measure. With trauma-01, they added an exclusion to the performance measure, or sorry, not an exclusion, an inclusion, but they're narrowing their net for inclusion here. In addition to having possible injury and a 911 response, they also need to have a GCS of 15, and they need to have a level of alertness, responsiveness as alert. And on top of that, they need to be treated and transported by this EMS unit for their disposition. So this significantly narrowed the net on trauma-01 to only include these records that had high GCS scores recorded, or the patient alert, or was treated and transported. So the net effect on these respecifications is that stroke-01, even though they were widening the net in terms of ICD-10 codes, they significantly narrowed the net by adding this exclusion criteria. So the number of records, last week, if you ran these measures, you would have gotten about 500,000 records that matched this criteria. Now that's down under 250,000. So that went down significantly. The effect on the actual performance, it went from 62% down to 59%. So it lowered the performance rate a little bit. With trauma-01, this additional inclusion criteria significantly dropped the number of records that are now included in the measure. We went from 10 million last week to 2 million now. So we down to just 20% of the number of records that we previously were looking at due to these additional criteria. The actual impact on what the performance looks like went from 58% up to 60%, so it increased by just a little bit. Okay, so that's the respecification of stroke-01 and trauma-01. If you look, if you're querying the web service, you'll see those new results today. If you are looking at the dashboard on the NEMSIS website, it'll be just a few more days before that dashboard does its weekly database refresh and catches the new specifications and new numbers. Going forward, we have several new performance measures that we will be implementing, trying to target one new measure every 2 months between now and the end of this year. Any questions on these performance measure updates? Okay, great. Well, that wraps it up for me. Julianne, back to you.
Excellent. Thank you, Josh. Next up on our agenda is Laurel. Do you want the screen, Laurel, or do you want me to put the agenda back up?
I'll take the screen.
All right.
All right, so you should now see the NEMSIS website. So my first item is the custom element library. So we recently made some updates to the custom element library to, first of all, improve its performance a little bit. And second of all, add a place for the national custom elements to live. So if you go to Technical Resources, National Custom Element Library, And then at the bottom here, just click Access the Custom Element Library, and it should come right up. One thing that you might notice when you get here is that there's now a loading bar that appears as it pulls up the custom elements in all of the states. So for me, I've visited this before. It loaded pretty quickly because it's cached in my web browser. But if it's your first time coming to the library in a while, or your first time since the update, it might take a couple of minutes for all the states to light up. You might notice down at the bottom that there are 2 new buttons down here, one for the National Custom Elements and one for the ET3 project. National Custom Elements should light up because we do have a National Custom Element. Hopefully we'll see some ET3 things soon, and that button will also light up. If you go ahead and click on National Custom Elements, you will be able to see our ePayment 05 extension on version 3.4.0. Just go ahead and click through, and it shows you basically the definition of that extended code list for ePayment 05. That's basically the extent of the changes here right now. This is only going to show you, this is not going to show you any new custom elements on anything like 3.5.0, just all of our existing custom elements, and now with the added feature of National Custom Elements and ET3 project elements when those are ready. Does anyone have any questions about this? All right, I'm going to take the silence to mean that everyone is super excited to implement the National Custom Element and has no questions. I'm going to move on to the next exciting topic. This one's more of a vendor kind of thing. So we recently updated our web services guide. So you can find that on the web services page, again, under technical resources. If you had visited this guide before, you might have noticed a couple things about it. One, it was very long. And 2, it was a little outdated. It was originally written when we first began version 3, and was maybe had more ideas for implementation than what we actually did to implement. So it's been completely revised to sort of reflect the current state of web services for NEMSIS and what's expected. If you visited this page before, you might also remember there was an error code supplement that used to sit between these 2 links. And that was also incomplete and didn't list all the error codes. So we've revised that to list all of the status codes, errors or success, and we've included that in the guide. So go ahead and open the guide and just really quickly flip through it. Much of the information will be familiar to you if you've worked with web services. The language has been revised to use the must, should, may kind of wording so that it's very clear what we expect and what is optional for web services. Not really any practical changes to the way web services works, but this guide is now probably a better resource if you have questions about implementation. I'm just going to continue scrolling here. Some example cases of submissions, and here's the status codes kind of near the end. We have everything from error codes to success codes. Here's some success codes. Result pending codes, query limit codes, and then the specification for any custom codes that a state or vendor could create in their own web service. Lastly, we used to have a guide on how to use SOAP UI, which is a piece of software that you can download to test a web service. We've removed that guide in favor of just referencing the official SOAP UI Getting Started guide. And we also removed it because there are a number of good software products you could use to test web services, and we recognize that SOAP UI might not be the only option people look at. So that's sort of a summary of what changed there. Does anyone have any questions in general about this web service guide? All right. Again, hearing no questions, I'm just going to continue on to my last topic. So we are going to be disabling TLS version 1.1 on all NEMSIS web services as of the April maintenance window, which, let me go to the NEMSIS website and grab that date. All right, April 14th and 15th is the April maintenance window. So during that time, we're going to disable TLS 1.1 on all NEMSIS web services. So if you have a system that submits to the National Registry, if you are using our performance measures web service, if you are attempting to compliance test on any of those web services, you will need to be using TLS version 1.2. Going along with that, we've added some documentation in this web services guide to cover the specification. NEMSIS systems should support TLS 1.3, must support version 1.2, and must not support versions 1.0 and 1.1. So for the web services you create, you should also plan to sunset 1.1 as well. The end of life for TLS version 1.1 is at the end of March, so that's coming up quickly. So that's TLS. Does anyone have any comments on that item?
So that's going to be part of compliance testing then?
At this time, we do not have any planned method to test which versions of TLS vendor support, but you will not be able to complete compliance testing unless you support version 1.2, unless you can send to us, because version 1.2 is going to be the only thing we have available as of April 15th on our services. And our current compliance testing services do not have TLS 1.1 anymore.
When you say systems, do you mean state systems or EPCR? Or?
So I'm not, this is a little above my head in terms of technical knowledge, but my understanding is that all NEMSIS compliant web services should adhere to this statement in the guide. And all of our services are going to support version 1.2 from April 15th until other associated technologies are ready for us to support 1.3. So if you're submitting, you have to be able to submit with TLS version 1.2. I'm probably wording that wrong, but that's my understanding from our operations team.
Yeah, I guess the wording is kind of ambiguous whether you're talking about the submitter or the receiver. So it just says support.
Yeah.
This is Josh. Yeah, that would be both ends of the handshake. So both the sender and the receiver should implement these requirements.
Okay, so all state repositories must deprecate 1.1 and 1.0.
Correct.
Okay. And that probably should be added to the compliance testing then, correct?
Yeah, as Laurel said, the compliance testing application will not support 1.0 and 1.1. So if you try to submit data in those versions, you will not be able to. I guess, yeah, Laurel, I guess you would need to look at testing state systems on what they receive, like trying to submit to them in 1.1 and seeing what happens.
Yeah, so that's an enhancement we'll have to look into for receive and process systems. But for collect and send systems, we already don't support 1.0. And as of today, we will not support 1.1. Thanks, Josh. Are there any further questions on TLS? All right, so I have one last topic, and that's the NEMSIS maintenance window for March, which is currently going on right now. So today, right now, as we speak, we are deploying the updates to compliance testing to support 3.5.0. Is there something in the chat? Yes, Zoom won't let me open it. Okay, it's another question. So if you were eagerly awaiting to apply for compliance testing on 3.5, now is your chance. Send in your application. If you've looked over the pre-tested cases and you've looked over the guide and you feel that you're ready to complete the active test cases within 90 days, please submit your application and we can get that process started. They're currently working on that deployment right now. Additionally, during this maintenance window, we are working on some enhancements to the website that will require a downtime. Our initial notification had approximated that it would be a 3-hour downtime, but I'm now being told it looks like it'll be much, much shorter than that, potentially under an hour. But as always, if our website is down, feel free to look at one of those Google Groups messages. I've dropped everyone's contact information there, so you can still get in contact with us if you need anything, and our website is unavailable. I think that covers everything. Does anyone have any questions about compliance testing on 3.5? All right, so I'm going to go ahead and turn it back over to Julianne since we're almost at 10:30. Thanks, everyone.
Thank you, Laurel. Next on the agenda, are there any issues or items from the Office of EMS?
Yeah, Julianne, I'm looking through the list. I think John was on, Gam was on, and Erica was on, but I think they had to jump off to go to a meeting. Okay.
Sounds good. Open forum, are there any other issues or questions that you guys want to bring up? I'm going to bring up one thing real quick. Barbara Stepansky shared some information for priority dispatch. She just wasn't able to unmute her phone, so I'll include that information when we send the follow-up information for this call. She's got there are a couple of guides for priority dispatch for infectious disease that we'll share with everyone. Are there any issues for open forum? Any questions, concerns?
I was going to ask about the 12-digit national ID and if that's being worked into NEMSIS or if there's any other relevant things for NEMSIS for us or for anybody.
Yeah, David, this is Clay. I'll comment on that briefly. We're still kind of working through that process with the National Registry, so we're working with Donnie in regards to the scope of that new EMS professional identifier and how it relates to other national provider numbers, and so whether it will become like another trackable value in NEMSIS is still kind of up in the air. So we'll be prepared to probably talk on that, David, in the next couple of calls and try to make folks understand better kind of the purposes of the National Registry tracking number.
Okay. And any states on the call, are there anything that you are doing to, I don't know, accept or prepare for that? Do you anticipate that taking place with your license numbers or anything like that, or what the things look like at the state level?
Hey, David, maybe we could ask the question, have any of the states looked into the new number that's being developed by the National Registry and kind of been tracking with it? Okay.
Yep. I guess not.
Yeah, David, we'll try to get some information out on this call related to it very soon.
Are there any other questions or concerns that any of the participants would like to bring up at this time?
Clay, can you guys just restate
exactly what our expectations for this national custom element conversation, what the next step is going to be?
Yeah, I just have my notes in front of me right now, so we'll meet together right after this call, and I'll make sure that I haven't missed anything. But our understanding is that we will put together a set of elements that we will be drafting that would be national custom elements related to travel outside of a community, and then probably an element related to a potential exposure to other sick people. I'll just put it very generic at this point. So those will come out. We'll build the attributes associated with those questions and those elements. So the pertinent negatives associated with those and the other kind of attributes of the elements. And so folks can look for any holes that may exist in those. And then we'll be sending out the codes that Brent sent from ESO regarding general exposure. So folks have a hold of those codes. And then Julianne, I think you mentioned that you have some priority dispatch codes that we'll make available as well.
Yes.
Yeah, sorry, I interrupted someone. Did I miss anything, Keenan?
No. So you'll publish out sort of what they will look like, and then when we reconvene, we comment on them, and then they go effective, or what's the plan past that?
Right. Yeah, that's the preliminary plan. We'll also call NHTSA. GAM at the Office of EMS is working as a liaison with the CDC regarding this issue, and so GAM's kind of leading it up. So he'll probably provide us with some guidance in regards to how quickly we move forward in publishing them and those kind of things. But I know everybody's very anxious to move quickly, so we'll do our best to move it along.
Okay. And you won't get those custom elements at the national level, correct?
No, we will not. Yeah, thank you for that clarification, David.
And there are a couple of states that have similar questions, and I think there's a question in the chat about how it will affect them. So Mississippi, Georgia, and maybe New Hampshire. Oh,
great. Okay, we've tracked all those comments, and we'll make sure that we review them carefully with this development. So.
Any other questions or concerns? Okay. Our next V3 implementation call will be March 25th, same time, same place. We'll be sending out some information later on today or first thing tomorrow morning with follow-up on this phone call, and also a location and where you can find a recording of this. We'll make this available as soon as possible. Thank you for taking time out of your busy days. We appreciate you being here. And as always, please feel free to reach out to us if you have any questions or concerns or need clarification on any of the topics that we discussed today. Thank you, everyone, for being here. We appreciate your time.